This is what I was just mentioning. Then any fluctuations in osmolarity, they will have a consequence on volume and so on and so forth. So we will be talking about three solutions in the following slide or two, and then we'll hop on to the clinical scenarios based on that. So this is basically forming your basic concept about fluids, then giving you simple examples, and then we move on to some complex real-time clinical scenarios to build up the final point. So isotonic solutions. Iso means the same. Isotonic, tonic means the relative concentration of solute and solvent. So isotonic means same as the body's fluids, both in terms of solute and solvent. Okay. So isotonic solutions is this. Hypotonic are solutions which are diluter as compared to the body fluids, and hypertonic, as the name suggests, are fluids which are more concentrated. They have more solute per unit solvent as compared to the body fluids. Okay, so this is the first slide which forms the basis of your concept here. We take a cell, very simply, and we place it in an isotonic fluid. You will see that the cell will not change in any way or form. Why? Because it is surrounded by fluid which is exactly similar with the fluid inside. And this is something that I want you to take a moment to let it settle in. If cells are surrounded by fluids, now remember, cells are surrounded by interstitial fluid, which is in direct link with vascular space, that extracellular space. The extracellular fluid bathes the cells. So if the cell and its surrounding, let's say the ECF, is in harmony of osmolarity, nothing will happen. Okay, so solute solvent ratio, solute solvent ratio is the same. Nothing will move in or out. It will keep its volume and everybody's happy. Okay, as you can see, osmolarity is 280, which is well within the good range. However, let's look at B scenario, the scenario B, in which you have put the same the same cell, but this time you have put it in a hypertonic solution. Now, simply putting the laws of osmosis, what will happen? If you put this cell inside a hypertonic solution, its interior, it has less solute per solvent as compared to its surroundings, right? So water will move from inside the cell to outside, and the cell will shrink, okay? And when it shrinks, its osmolarity increases, okay, simply. And C again is in the same principle, follows the same principle. If you put the cell in a hypotonic solution, the reverse would happen. The inside of the cell, the outside of the cell has less amount of solutes per water, and water is more. And here, the water will find that the solutes are more, so it will just enter the cell and swell it up, decreasing its osmolarity to 200. I hope this simple but very important concept is clear, because we are going to build on this in the next slide and so on. Now, using the same concept now, we are doing three things in this slide. And I need your complete attention. So this pink thing, red, whatever, is the intracellular space. The yellow is the extracellular space in a graphical form. Along the y-axis, you see osmolarity, and along the x-axis, you see volume in liters. This is the normal state. Nothing has happened. Now, in this state, first scenario, you add isotonic NaCl. Now, you know now that isotonic means the same tone, the same osmolarity volume ratio of fluid as the bodies. So when you add isotonic NaCl, and we have mentioned already that whenever you take anything or extract anything, it basically deals with the, firstly, the extracellular space. So you need to make a habit that whenever you give the patient anything, or whenever for the same point, whenever you take anything, food or water or any drink, basically the ECF gets affected first, just like in this example. And you need to start your analysis by assuming that first the change will hit the extracellular space and then the intracellular space will respond. This is the way you solve these issues, and it will get complex in the next slide. So stay with it, stay with the technique that I'm telling you. You gave this person isotonic saline. Saline is another way of another word for sodium chloride solution. Isotonic saline given to this person, it hits his extracellular fluid. Now the extracellular fluid's volume increases. As you can see, it's along the volume. The arrows indicate that the volume has increased. Nothing has happened on the intracellular side. It's just that the extracellular fluid has increased in volume. Why hasn't this responded? Because it was isotonic. No osmosis could take place because it's really the same thing. And what about osmolarity? Did osmolarity change? No, no, sir. How would it change? You have used isotonic. So what basically you've done, you have sort of taken a fluid which is exactly like extracellular fluid, and you've added it to extracellular fluid. The change in volume will be the only thing that has happened. So patients of shock, when they come, the first thing that you would like to do is enhance their ECF volume, okay, by giving them isotonic saline. When you give them isotonic saline, ECF volume improves, and you know that ECF includes the vascular compartment. So basically you're adding fluid to the blood. Now in a shock patient, the blood pressure has plummeted. So if you add fluid inside the blood, it will improve the volume. Volume improves pressure. Blood pressure gets improved. The person is helped in his shock. Okay, there you have it. Now, look at, let's take this. Look at this. You add hypotonic saline. Now, you added it in the extracellular compartment. Okay, what has happened? It is hypotonic, i.e., it is diluter than your ECF compartment. What will it do? It will decrease the osmolarity, increase the volume naturally. Okay? Then what happens? Then what happens? This is diluter, and this is more concentrated as compared to this new reality that you have created. What will happen is then water will start to enter the intracellular space, okay, increasing its volume. So you have stretched the graph here, right? So hypotonic solution here finds more solute inside. Osmosis says it enters the intracellular space, and you have an increase in volume of the intracellular compartment at the expense of its osmolarity. Because when water enters it, naturally it becomes diluted as well. The osmolarity congruently comes down. And then the steady state, one thing I forgot to mention, that whenever you're discussing these things, there are 3 steps. One is the initial event, adding whatever you have added or subtracted whatever you have subtracted. That's the first stage. The second stage is how did that affect the ECF and the associated ICF. The third point is when the dust settles, everything settles, what is the new reality? That was, I forgot to mention that. So quickly, the comment about this isotonic solution is when everything settles down, the net result is that you have expanded the ECF, the ICF remains the same. Okay. So coming back to this example, what is the net result? The net result is you have expanded the volumes of both ECF and ICF. So the water content in both of these examples has increased, okay? And you have decreased the osmolarity of both chambers, ECF and ICF. So that's that. So now coming to the final point, if you were to introduce hypertonic saline to your case, so again you do the 1, 2, 3, you add hypertonic saline. Now hypertonic saline means that the osmolarity will increase. Naturally the volume will increase as well, but basically the osmolarity will increase because it's hypertonic. As soon as this chamber has more solutes than its cousin, the intracellular space, what will happen? The fluid will start moving out. The fluid starts moving out, and it's just the reverse of this really. When it moves out, it stretches it, it adds to its volume, and at the expense of its own volume, we say that it contracts the intracellular compartment shrinks because the water is now exiting it and adding to the extracellular compartment. And at the same time, because water is leaving, the osmolarity of the chamber increases. Okay, so that's how the reaction of the ICF was to the main event in the ECF. The third point is, when the dust settles at the end of the day, what have you done? By adding hypertonic saline to this case, what you have done is that you have increased the osmolarity of both chambers, you have shrunk the intracellular volume, and you have expanded your ECF. This is the final point. Okay. So I hope this is clear, because this is going to be exploited now in the next slide. So now we're talking about clinical scenarios, actual scenarios in which changes in ECF volume or osmolarity has effects on the what you call the intracellular compartment. A word of caution here is that this slide, if I should mention it right here, this is solution form of sodium chloride. So you are using isotonic saline, which basically means that you have mixed an appropriate amount of salt in equal amount of water and then given it to your case. Here, you have kept it diluted. You have used less salt in water and you have given it. Here, you have used more salt. If I can tickle your thinking a bit, what if I were to use only salt? Let's check this out. If I were to use, let's say here, if there is no water in this scenario, I were to just take out salt out of the ECF, what would happen? Let's run with this. So the event is not that you have added a dilute sodium chloride solution, but actually you have removed sodium chloride from this chamber. In terms of osmolarity, it's really the same thing, right? Now, what you have done is, in the same volume, you have taken out sodium chloride. So this has become dilute. As soon as this becomes dilute, water will start moving into the ICF, increasing its volume and making it a diluter. So the osmolarity will come down. Okay. So what the change would be, there won't be any significant volume change in the ECF if you only used salt. I mentioned this for a reason. Let me just complete this as well. In this solution, you just put salt in. You just added salt without any water, attending water. You put salt into the ECF. Now what will happen? Water will come from the ICF into the ECF, expanding its volume and raising its osmolarity. While in this, it will increase it will increase its osmolarity in return. The reason I mention this, the difference, is that in the body, so the kidney has this very prominent property of handling sodium and water together and separately. Okay, we will talk about the single effect in a specific scenario, but at the moment I'm not referring to that. I'm referring to the fact that there are mechanisms by which kidney can reabsorb water only. And just to mention it here so that you remember what is being talked about, it's basically ADH. ADH is a hormone which is released by the posterior pituitary. It's antidiuretic hormone. So when antidiuretic hormone acts on the kidney, it basically stops the diuresis. Diuresis is formation of urine. It acts against the diuresis. It reabsorbs extra water, which would have gone off into the urine. So it conserves water, okay, by reabsorbing it, which when it naturally wouldn't have been reabsorbed. So water basically can be manipulated as a separate entity, separate from solute. These scenarios basically talk about salt and solvent together. And that's why this is all fine. But in clinical scenarios, there are scenarios where only water is manipulated by the scenario, or only sodium is manipulated by the scenario, not water. So your concept needs to be along those lines, because this is reality. This is what actually happens. Hyponatremia and hypernatremia is discussed in Guyton actually very well. Okay. And when you read that chapter, you'll know what I'm talking about. So hypernatremia is when natremia is natrium is sodium basically. Hyper means extra sodium in ECF, and hyponatremia means less sodium in ECF. Okay, and so on and so forth. So with that in mind, let's hit the mother load here. Now this is I would say a simplified table. You may not agree with me, but give me a few seconds, you'll agree with me. In which the type of event is discussed, is mentioned here. Okay, just follow the cursor. The actual real-time example of this change is mentioned right next to it. And then there are 5 parameters which are discussed. What happens to the ECF volume, what happens to its osmolarity, eventually what happens to the ICF, and there are 2 additional matters: what happens to the hematocrit, and what happens to the total body, total water content as a result of whatever you did here. Okay. Now these are color coded. The yellow is basically, if you want to just give this whole nice chart a key, the yellow stuff is all volume contraction. So something is happening where ECF volume is decreasing. Okay, so this is not rocket science here. Yellow stuff is basically decreasing ECF volume. But let me just say, complete this argument first. The blue stuff is increase in ECF volume. So volume expansion. As you see, the name is connected with ECF. I'm not mentioning ICF at the moment. I'm just mentioning ECF. So if I say volume contraction or volume expansion, you should naturally go for ECF volume contraction or ECF volume expansion. Having done that, let's look at the yellow trio. One is isoosmotic volume contraction. The other is hyperosmotic volume contraction. The third is hypoosmotic volume contraction. So whatever is happening here, it's happening to both solute and water in the same ratio. Very important. Here, whatever is going on, it's contracting the ECF volume. It's changing. It's shrinking the ECF volume, and it's doing it only to the water, because what is left is hyperosmolarity. So clearly, there is something. What is going on is water is leaving, or water is not enough, or whatever, and whatever is left behind is hyperosmolarity, right? And the opposite is hypoosmotic volume contraction. So whatever volume contraction is happening is basically, what is happening is you are also losing solute with it. Now let's give these real names. So in diarrhea and burns, what you lose is you lose your fluids. For example, in diarrhea, you lose intestinal fluids, which are isotonic with the ECF. So they are same part, equal part salt, equal part water, just reflecting the ECF. Okay. So, and same is the case with burns. So see how I manage to decipher this whole data. ECF volume would naturally go down because you're losing fluid, isotonic fluid. Okay. What will happen to osmolarity of the ECF? Nothing. No change. Nothing will happen. What will happen to ICF volume? Nothing. No change. Because osmolarity is not disturbed. So nothing will happen to ICF volume. We have done this. We have already made this concept. Okay. I won't comment on hematocrit. This is for you to work out. If you have any questions, you can always ask me in the comment section. I will, if time permits me, explain right at the end what's happening here. Okay. Anywho, so what about the total body water? What happens to that? So if you are to calculate just the volumes, this volume is not changed, but this has decreased. So if you're calculating both, then naturally that total body water will be decreased. Okay. If this is clear, then this will be less difficult. A hyperosmotic volume contraction happens when you deprive yourself of water, when there is fever, or when there is diabetes insipidus. All these scenarios, I'll explain them just a bit. All these scenarios, basically, there is less water in the body. Solute remains the same. The water deprivation example is self-explanatory. Fever. In fever, you lose water from evaporation, okay, from different mechanisms. So solute is the same, okay. Would sweating be part of this? No. In sweating, you lose both salt and water, so it can't fit here. The only list here is if water selectively goes out. Diabetes insipidus is when ADH is not working somehow. We'll discuss this later on. So the body is in diuresis, it's losing free water in urine, and there is no stopping it. Okay. Now, in this situation, what will happen to ECF volume? Again, it's the same analytical technique that we used in the first line. ECF volume is going down. But now, since only water is going down, not solute, the osmolarity increases. Yes? In this case, both salt and water were being lost. Here, only water is being lost, and what remains behind is that same solute. But now, when the ratio, you make a ratio of solute per solvent, the osmolarity increases. Okay. So as soon as the osmolarity would increase in the ECF, you know what happens to ICF. ICF water will start coming out. Okay. So ICF water in this volume, in this case, will go down. Okay. And when you comment on the total body water, naturally, it in both the volumes, it has gone down. Okay. Coming to the third point, hypoosmotic volume contraction. Now, in hypoosmotic volume contraction, what happens? It happens in adrenal insufficiency. Very briefly, there is adrenal gland. It secretes many hormones. Both its medulla and its cortex releases enzymes, hormones, which are very, very important. The two famous lifesavers are aldosterone and cortisol. Both are released by adrenal cortex. Now, adrenal insufficiency, basically, we are looking at, in this context, we're looking at aldosterone. Okay. Aldosterone basically works at the distal end of the nephron inside the kidney and reabsorbs sodium, helps reabsorb sodium. So the sodium which is on its way or would have been excreted in urine, aldosterone, when it's there secreted, it reabsorbs, it pulls back that sodium back into the body fluid. If you have a problem with adrenal gland itself, then what happens? Then what happens is sodium is lost. Okay, sodium goes out of the park, and this is exactly what I described in the previous slide when we were talking about the hypotonic scenario. But I told you that we took a solution, a diluted solution, and added to the ECF. But in real body, you can have a situation where you just remove the solute. Just apply that here. Okay. So what happens is osmolarity goes down because you have taken solute sodium out of the ECF compartment. Okay, you have made it more dilute. The volume would go down, and ICF volume will go up because the water will travel from the ECF compartment into the ICF compartment, raising its volume in the but as a result, it will contract itself eventually. Total body water in this interesting example remains the same because water is just shifting between the two chambers. There is no net loss of water because your main issue was with sodium. Okay. Uh, However, I would give a footnote here that sodium does travel with its in its hydrous ion, and it travels with water. So there will be a slight water involvement as well. But strictly speaking, if strictly speaking we are just looking at sodium, then yes, it will disturb the osmolarity, make ECF dilute. That dilute ECF water will travel inside the ICF, increasing its volume and eventually decreasing the ECF volume. Okay, so these are the three scenarios of volume contraction. Now let's go to volume expansion. Isomotic volume expansion. Again, you can just follow the same rules of engagement. Infusion of isotonic saline. We've done this already. ECF volume goes up. No changes in osmolarity, hence no change in ICF volume. Hematocrit, I said I won't comment, but let me just add something here. It will be diluted because you're adding fluid in the ECF, which will dilute the blood. The total body water goes up. Hypertonic. So if you were to take a high NaCl intake, so you are adding salt to your ECF, what will happen? The osmolarity goes up. Now, when osmolarity goes up, what will happen? The ICF water will go into the ECF, raising it, and in return, it will decrease. Simply put, and since these changes are no net water has been added or taken away, it just has shifted between compartments, no change in total body water. Okay. Now, the last point is hypoosmotic volume expansion. SIADH, it's syndrome of inappropriate ADH secretion. So S is for syndrome, I is for inappropriate, ADH is for that hormone secretion. So there is some sort of a tumor or somehow there is increased ADH in the system. Okay. Now you have, as I already told you, ADH reabsorbs water. When it will reabsorb more water than solute, selectively more water than solute. This is where, again, the separation of solute and water comes in when we're talking about the body, human body. The osmolarity goes down and ECF goes up, and it also enters into ICF because of osmosis, and this goes up as well. So the net is both volumes go up at the expense of osmolarity because you have a tumor which is secreting ADH. The total body water also expands. Now what happens here? I said, I promise I will comment on the hematocrit. Now hematocrit, as you know, is the ratio of cellular component to plasma. So basically, the blood now is diluted in the sense that it is in a chamber which has more water. So you can say that it has diluted. So why is the no change? It should say dilute. No, because secondly, blood cells are cells themselves as well. So they will also have fluid entering into them, enlarging their size, and hence enlarging the hematocrit. Both of these effects will cancel each other, and hence you will have no change in hematocrit. So this is this. I hope this is clear. As you can imagine, the amount of MCQs or Viva questions that can be asked from this, we can use these words to make MCQs, or if you are having a bad day, we will use the scenarios, the actual scenarios, and ask you the same thing. Or we can give you, if you are having a really bad day, we can have this scenario here, give you a scenario. Let me help you here. The typical scenarios would be of diarrhea. Uh, this one here, diabetes insipidus is a favorite, and SIADH. These are typical questions in renal physiology. So I suggest that you do the whole thing very, very well in every respect, every angle. But when looking at your MCQs, look out for MCQs on this, here, this one, and this one. Okay, so that's that. This I really liked in Guyton. It's a lovely information. Acute versus chronic changes. Now, let me take it slow. This is the brain. Okay, the brain has solute to water ratio, and then ECF has sodium and water ratio. Why have we just taken sodium in the ECF while we mentioned potassium, sodium, organic ions, etc. in the brain, i.e. inside the cells of the brain? Is because in ECF, sodium is overwhelmingly more. It just dominates the ECF in ions when we talk about ions. So we just, for simple purposes, we just mentioned sodium and water. Also, when we talk about osmolarity and volumes in renal physiology as well, we basically look at sodium because it's just an abundant ion and is a very effective osmol, i.e. its effect on solute, on solvent, I beg your pardon, is tremendous, which is not shared by potassium or other organic solutes. So that's why sodium is the hero, is the reference point of osmolarity and volume discussions in renal physiology. Okay, so this being the brain, and this is the ECF. He is now talking about normonatremia, that sodium is normal, everything is nice, nothing is happening. Okay, now you create an acute hyponatremia. What you do is you dilute the ECF. You either take sodium out or raise water, whatever. These both are really the same thing. But yes, there are actual scenarios where only sodium goes down and only water goes up. SIADH is one example where this would happen. Or this hyponatremia is isolated changes in sodium concentration specifically are less common than water fluctuations. Anyhow, so when you have acute hyponatremia, what happens? Number one, uh, it's dilute, so water will, again osmosis, water will enter the brain cells where it finds more solute. Okay, so water will enter. Now eventually what happens is that the brain literally swells up because the cells now have more water than before. Okay, uh, what will happen is, uh, hold on, what's yeah, so water comes in, it swells up the whole thing, and that's what you will have. But what then happens is sodium and potassium and other organic solutes, they start to leave. Now this is where I will mention a term called electro neutrality. So, and this is where I did mention a comment or two just earlier, that if the thing is addressed, that's fine. But if it stays there, then it's at a cost. If you remember, I did say something like that. So here, this is is a very good example. So the initial event was decreasing sodium or increasing water. What happens is water then, by osmosis, enters into the brain cells, swelling increasing the water content of brain cells. Okay. Now, if the initial insult, this remains there, it's not addressed, then what happens is that for electroneutrality, these ions will start leaving to balance the electrical imbalance. Okay. Now, because look, if you decrease, if in those terms, if you decrease positive charge here, and there's more positive charge here, naturally it will go out to balance out the less positive charge outside. So this happens. Okay. Uh, and when this happens, uh, eventually there is balance of solute, and then water also readjusts accordingly. So that if you do not improve your hyponatremia, eventually what would happen is that you will have the same scenario, i.e. this you did not correct, but the brain will sort itself out. How? At the expense of decreasing its solutes. Okay. So it will get rid of these solutes. They will go out, okay, to create electro neutrality, and they will be less, they will decrease, and the volume will adjust back to uh, almost previous normal volume of the cells. So in this whole example, I hope you realize that if the initial insult, the initial event, if it were sorted out, then this whole thing wouldn't have occurred. So in the previous example, we assume that all those volume shrinkages or volume expansions, they were addressed quickly by the readjustment, immediate readjustment of the corresponding ICF. However, if the thing stays, it becomes chronic, then eventually ions also start to readjust themselves. Uh, they decrease in their amounts accordingly. And so volume is achieved at the expense of osmolarity. Okay.